Hi, everyone. Thanks so much for joining us today for the New Parents Conference with Dr. Jennifer Miller. Um, I hope that everyone has had a good week. It looks like a lot of us are already signed on, so I'm just going to go ahead and jump in. Um, my screen would cooperate. Uh, my name is Sarah Peden, and I'm the new parent committee chair for the Foundation for Prader-Willi Research. Basically, that just means that I get to talk and meet with a lot of you and just kind of get you plugged into the community. And every once in a while, we get to have these great webinars, and everybody gets to connect. So if you don't receive emails about the webinars, please let me know. By either emailing me or finding me on Facebook, and just let me know so I can get you plugged in to receive the updates for the upcoming webinars. Today, we get to talk to Dr. Jennifer Miller. No, there are more to come. I actually collected all of these photos just today. It's amazing how many there are. So anyway, for everyone out there, we encourage your participation. This webinar is all about your questions and answering your questions. So right now, there's a little question box over on your control panel. Go there and type in your questions now. That way, when we get to that point, I'll have them ready. Just as a reminder, we're keeping this on growth hormone questions and questions related to growth hormone. Also, you're all muted right now if you haven't noticed. We do that so that there isn't a lot of feedback. And as I get to your question, I will unmute you. So I'll give you a warning. I'll read your question, and then I'll say I'm going to unmute you, and then I will unmute you. So that's your warning. Okay, so Dr. Miller is a board-certified pediatric endocrinologist in Gainesville. She's affiliated with Shands at the University of Florida and is an sorry, something is beeping at me. Associate professor at University of Florida College of Medicine. Oh my goodness. Sorry, my phone is going crazy. In medical school, when she was studying the link between obesity and brain development, her interest was sparked not only in endocrinology, but also in Prader-Willi syndrome. And we are also grateful for that. There's all the information about schools and how smart she is and all of the things that she's doing. But basically, Dr. Miller is our hero. I just absolutely love you, and I know that everybody else feels the same way. We're so thankful for your enthusiasm, and I truly believe that PWS would look different today if it wasn't for you. So thank you, and thank you so much for taking the time to talk to our new parents today. We really appreciate it. Is there anything that you want to say before we get started?
No, I'm happy to answer any questions, and you embarrassed me, but that's okay.
Well, that was nice. Okay, there's a lot of pictures in here.
At least I'm wearing mostly different clothes in all these pictures. They're not all the same outfit, so that's good. Looks like I actually shopped.
I actually noticed a theme, and then as I'm going back, I had to rack my brain, and I was like, that was on the same day. So some of these photos were taken on the same day. But see, look, there's more. The black and white striped shirt, I really like that.
Yeah, I apparently wear it a lot.
Okay, so our first question comes from Katie. It looks like Morrow. Katie asked, how do you know when to increase the growth hormone? And I'm going to go ahead and unmute her so that you can talk directly to her.
Okay.
Katie. All right, Katie, I'm unmuting you.
Hi, Katie.
Hello.
Katie. Hi.
Hi.
All right. So to answer your question, every endocrinologist does it a little bit differently, but in my clinic we use several parameters. We use how the child is actually growing, as well as their IGF-1 levels. If they're not growing well, then we know we have to increase the growth hormone. If their IGF-1 levels are less than about halfway through normal, we want them in the upper 2/3 of the normal range, then we'll also increase the growth hormone at that point in time. Even if the child is growing well, if the IGF-1 levels are on the lower side, we will go ahead and go up on the growth hormone, because we know leaving them at that IGF-1 level over time, they will start to not grow as well.
Okay. And how do you track that being long distance? Because I know a lot of the clients, like, we're going to see you in May, but we, like once a year. How do you track that then, like, to keep up on what the levels are?
So I have parents that live further away send me weights and heights every few months. It depends on the child and the age of the child. Everybody is a little bit different, but when I see you, we'll talk about that. And then we do the IGF-1 levels. I usually order them and ask your pediatrician to rewrite them so that they'll be paid for by insurance. And then it's just a blood test that you do, and then you or the pediatrician sends me the results, and we look at them together.
Okay. Thank you.
Mm-hmm.
Thanks, Katie. I'm going to mute you now. And our next question is from Louise, but she does not have a microphone, so I'm just going to read it.
Okay.
And see if we can get it answered. So her question, it's so small, sorry. It says, we are waiting on oxygen for our son to have during sleep, over 1 hour. The recommendation was to get this organized and another sleep study done in 3 to 4 months before they look at recommending growth hormone. I am in Australia. This recommendation was made because his sleep architecture is still immature, neonate-like. His oxygen drops below 90 during central apnea episodes. Would obtaining the oxygen be enough to warrant the introduction of growth hormone in your view? I believe your research shows it can improve sleep-disordered breathing. Can you confirm this? Also, when or would it even be recommended to have tonsils and adenoids removed as a preventative for OSA?
So it's a very good question, and the answer is she is correct that growth hormone can improve sleep disordered breathing. The oxygen is definitely essential for central sleep apnea to keep his breathing normal and his oxygen levels normal during the night. But once you've got that, you should be able to start growth hormone safely without having to have another sleep study, in my opinion at least. We've shown that growth hormone definitely improves both central and obstructive sleep apnea, especially in babies, because it makes them stronger and it matures their brain a little bit faster so they get better. Oh, God, I already forgot the second part of the question. I apologize.
Okay, let me go back. Sorry, I have to scroll through. Would obtaining oxygen be enough to warrant the introduction of growth hormone? Also, when would it, or would it even be recommended to have the tonsils and adenoids?
That's the question. Yes. So that part there is no real good answer for. Some people have advocated, yes, taking tonsils out preventatively, because we know that a lot of kids, especially in the preschool age range, will end up with obstructive sleep apnea due to tonsil and adenoid growth because of the combination of illness, being around other young children and being on growth hormone and having a narrow airway to start with. Some people have said that taking out the tonsils and adenoids doesn't really seem to make a huge difference in terms of preventing those problems when the kids are that age. So we don't know the answer. I actually, because it's a surgery, I don't recommend doing it prophylactically. If your kid doesn't have any problems, I don't actually usually recommend taking out the tonsils and adenoids until there is a problem. I feel like, it's a surgery, it's anesthesia, it's painful. There's just a lot of risks to it that I'd rather not take unless we have to.
Okay. Hopefully that answers all the questions for her. So I'm going to go ahead and move on to Natalie. Natalie's question is, please, can you explain the general guidelines regarding use of growth hormone when ill? And I'm going to unmute Natalie so she can chat with you. Natalie, are you there?
Hi, yes. Hi, Jennifer. How you doing?
I'm good. How are you? So the answer is, again, there's no real consensus. As you can probably get a sense of, endocrinology is really kind of the art of medicine. There's nothing that says that taking the child off growth hormone during a time of illness is beneficial in any way. However, because we know that back in 2003 when those deaths occurred on growth hormone, we know that those were associated with respiratory illnesses. I tell my patients, it's up to you, but if it were my kid and they had a respiratory illness, and especially if they had just started growth hormone, I would probably take them off during a respiratory illness if they were having, problems breathing, they were snoring, they were really working hard to breathe, or they had a pneumonia or something like that. But there's absolutely nothing scientifically that says that that's the right thing to do. That is my just sort of gestalt, how I manage it, because, that makes me feel better. But honestly, there's nothing that says you have to do that.
Okay, thanks.
Mm-hmm.
Yeah, it seems that there's, varying degrees, and obviously, as you know, with our kids, those respiratory illnesses can tend to go on for several weeks. So
Right.
I guess as a mother, you just have to take a call on when you think that they're struggling to breathe, or when they're not, or when they're getting a bit better and can perhaps start using it again.
Exactly, and that's usually what I say to people. When they're at their sickest, they're working really hard. You can see them tugging to breathe under their ribs, or there's, like I said, they're snoring, they're really coughing, congested. That's when I would hold it. But you're right, they can last forever and ever with just that, kind of yucky cough that they can't get the secretions up. But as long as they're breathing okay at night, I feel like it's okay to go ahead and restart it whenever you feel comfortable.
And there's no real detriment in the long term, like a grand overall scheme of things, to sort of stopping for a week for that reason.
No,
Is there?
not
There's
at
no
all.
sort of backwards progress, right?
Exactly, not at all, not for that short a period of time.
Okay, thank you.
Mm-hmm.
Okay, Natalie, I'm going to mute you now. The next question is from Ashley Gamble. Ashley, I'm going to unmute you. And her question is, how often should she get IGF levels checked? Ashley, are you there? Hello?
Yes, I'm here.
Hi.
Hi, hello.
Hi, Ashley, how often does your endocrinologist check them usually?
Well, actually, after speaking with you, she was allowing us to start growth hormone for Nora, but she.
I know who you are.
Yes. What's that?
I said, now I know who you are, Nora.
Oh.
See, I always remember the kid's name.
Yes. So, yeah, I just don't know. I mean, maybe she's spoken with you too, but for my sake, I just didn't know how often those should be drawn.
So Nora's pretty young, right? She's a baby?
Yeah, she's going to be actually a year, May 2nd.
Okay. So most of the time, the most rapid growth when you first start growth hormone usually occurs within the first year. By 2, most of the parents can tell you that around age 18 months to 2 years, the kids are on a dose, and it's sort of a stable dose that they stay on for a very long time after that because the growth velocity slows down at 2. So because she's going to be between 1 and 2, I usually check about every 3 months. When they're babies, sometimes I'll check more often, like I'll change the dose and I'll check again in a month. But after age 1, the growth velocity is starting to slow a little bit. So you can space it out a little bit more and do it like once every 3 months or so.
Okay. All right. Thank you very much.
No problem.
Thanks, Ashley. Okay, Ashley, I'm muting you now. And let's see, the next question's from Ponder Bishop. It says she doesn't have a microphone, though, so I will go ahead and ask her question. It says, my daughter Juliet will be 2 next week. However, none of her doctors have done blood work. Her only blood draw was done in the NICU. She is on growth hormone and has been on it since 3 weeks old. What types of blood work should I request?
Yeah, so she definitely needs blood work. So she needs an IGF-1 level just because she's never had one. She, at least once a year, we almost always do things like liver and kidney functions, a complete blood count, When they get over 3, we'll do cholesterol. We'll do what's called a hemoglobin A1C to look for diabetes. Again, that's usually when they're over around 5. But for right now, and thyroid's the other big one because it can go along with growth hormone deficiency. So I would say that now she needs an IGF-1, thyroid functions, liver and kidney functions, and a blood count at the very least.
Okay. All right. Ponder, hopefully that answers your question. We're going to go ahead and move on to the next one. It is Angela Lachney, and her question is, our baby is 7 weeks old. How old does he need to be to get growth hormone started? And Angela, I'm going to go ahead and unmute you. Okay. Are you there, Angela? Doesn't sound like it. Hello?
That was me.
Okay. Well, I unmuted her, but it might just be a microphone issue. So her baby is 7 weeks old. How old does he need to be to get started on growth hormone?
There is no specific age. As you heard, somebody started at 3 weeks of age or 10 weeks of age, something very young, and some people start around a year. We found in a study that the greatest benefits from the growth hormone do come as long as you start before a year of age. But we didn't have enough kids to sort of tease out, was it better to start at 3 months of age versus 6 months of age versus 9 months of age? We really don't know. We just recommend going ahead and seeing an endocrinologist and getting started as soon as you can. Growth hormone deficiency typically manifests around 6 months of age. And so I like to try to treat by then if possible, but if not, I really like to try to treat before a year of age.
Okay. And she just typed in, and no, she does not have a microphone. So thank you for answering. The next question is Andrea Piercy, and it's a pretty long question about growth hormone and levels and all kinds of stuff. So I'm just going to go ahead and unmute her and let her ask the question.
Okay.
Andrea, are you there?
Yes. Can you hear me?
Yes.
Yes.
Okay. Sorry. Yeah, it's long. So I've emailed you before. You probably remember Dr.
I was going to say, I know the name.
So anyway, I went off the sick and not sick thing with that as well. Maya's been sick so much. She is sick more than she's not sick. She has had, I think, 10 days in the last month and a half without a respiratory illness. We don't take her off because we have taken her off once during a really bad pneumonia in the ICU. And
Dr. Stafford made you put her back on, right?
That was a different hospital stay. When she was transferred, then she did say put her back on it. Don't take her off it. Don't without talking to me because that's going to benefit her more than it's going to harm her. Was basically her argument. So we keep her on it. The problem with that is, like all babies with Prader-Willi, she has a very tough stick, and neither of the labs at the hospitals have been able to get her levels. And so when we get them, we usually do it tied to a surgery, or now her complex care doctor just does it in her office. And so we got numbers in January during a surgery, and she was on 0.2 for 5 months, and she was on 0.3 for 2 months. And then in January, we got the levels, and they said, I didn't write it down, but I know that she said in January her IGF-1 was 25. And then they upped her to 0.4, and her doctor, complex care doctor, got her blood in March, and she said she either went up to 228 or 288. I can't remember. That's a huge jump in my mind.
That's a huge jump.
So she said whatever, she said, the number's within normal range, so we're going to keep her. Now, this was from the complex care, not the endocrinologist, but she said in range, so it sounds like we have a good dose for her.
Yeah, I would agree.
My question is, Maya's way delayed, even compared to the PWS peers. That number 25 seems so low to me. Does that mean she wasn't really getting much benefit of all that time on GH?
Right, I would agree. Unfortunately, yes.
So those were just a bunch of needle sticks that. Okay.
Right.
So what
they probably did something, but it wasn't maximized. It wasn't optimized.
Okay. So Okay. What did the like 228 to or 288 mean for like she's 16 months old and like I don't know where she would fit. Like
So that's optimal dose right now is what she's on. That's right at the top of the normal range for her age, and that's right where you want her. So yeah, so now she's on the right dose.
yeah,
And you know, every kid is a little bit different. You know, some kids make some growth hormone, some kids don't make any growth hormone, and so you'll see a huge range of doses between 0.2 and 1.0 in kids her age, and it's just because everybody's different. Some kids need more because they don't make any, and some kids need less because they make some. You know, so I don't think all those growth hormone sticks didn't do anything. I think they did something, but obviously they didn't do as much as you would have hoped. You know, and so now though that she's on the right dose, I would expect that you should start to see some improvements in her motor skills and in her speech and that kind of stuff.
yeah, which we've seen more just in the last couple of months. But
Yeah.
doesn't that seem like a big jump from like even if she'd been on that 0.3 to 0.4? Like
Yeah, I suspect that 25 was wrong. I think it was a lab error, would be my guess. My guess is they measured something called an IGF-BP1 instead of an IGF-1. Happens all the time, and that lab value is useless. So my guess is that that was probably wrong, but I don't know the answer without looking at the actual paper.
okay, yeah, they took a bunch of blood, so and they were kind of fumbling to get all the right stuff the morning of the surgery, so could be okay.
Even more likely that there was a mistake.
Well, hopefully we see more growth and with the 0.4.
I think you will. Now, I have a question for you, and this is off topic, Sarah, and I apologize. But have you tried, like the Pharmanac? I know it's not available right now, but have you tried it for her respiratory stuff?
No.
Do you know what that is?
Is that the one they use for skin picking?
It sure is, and it's also used for cystic fibrosis. It loosens up secretions, and so a lot of kids have had great success staying out of the hospital during the winter when they take the Pharmanac because it loosens up those secretions, and you can put one of those vests on the kid, you know, and that vibrate a little bit and help her cough that up so that she can not get secondary infections whenever she has a cold.
Yeah. I'll have to run it across them. I mean, they put her on like the saline nebulizers to break it up, just barely.
Exactly. But that doesn't. So the problem is, though, it's still pretty thick and viscous, even with the saline, and she can't really cough it up. And that's what she needs to do is get it up and out of her lungs.
Okay. They did notice too that her immune levels are low, so she is going to an immunologist soon. So
Okay.
hopefully that'll help. But anyway,
Seriously, because the kid didn't have enough issues, right?
Yeah. So, okay. Well, thank
All
you.
right. Well, and feel free to email me if you have any questions about that.
Okay. Thanks.
Mm-hmm.
Thanks, Andrea. I'm going to go ahead and mute you now. And let me go on to the next question. Let's see. Ariel McKay has a question about growth hormone and improvement with tone. Let me find her and unmute her. Ariel, are you there?
Hello?
Hi.
Yeah, can you hear me?
Yep.
Hi. Okay, so my question is, my son's AJ.
Yeah, I know.
When we
I was like, why didn't you?
when we started the growth hormone, or before we started, I should say, his tone wasn't completely normal, but it also wasn't very low. He seemed progressing at an okay pace, and then we started the growth hormone at a 0.4, and I want to say for like the first month when he was on the 0.4, we saw huge improvements with his milestones. But then after that first month, he seemed to kind of, I don't want to say not progressing. Yeah, he just wasn't progressing anymore. I don't know, it seemed like he kind of plateaued almost. So then we kept on that dose for about 2 more months, checked his IGF-1 levels, and they were about 64, and then you actually had us increase to the 0.5. And almost instantly after we increased, he started to take off again. So is that just, what are the IGF-1 levels exactly? I'm a little confused.
So IGF-1 is just a surrogate marker for growth hormone. When growth hormone binds to its receptors, it makes IGF-1. And we can't measure growth hormone itself in the blood because we're giving it. And so if we measured it, it would just be a useless value. So we measure the IGF-1s as a surrogate marker to see if there's enough growth hormone there. And it's actually the IGF-1 that works at the muscle and the bone and stuff like that for the growth and the strength. So that's why we look at that particular number.
So the reason that he may have plateaued while he was on the 0.4, just he wasn't making enough growth hormone?
Correct. And he wasn't getting enough either, you know, so he got enough at the beginning, but then he grew and he probably needed more. So, so that's probably why.
And as far as the child plateauing or not making progress like they were, is that a good indicator that they need an increase?
Usually, it's usually a very good indicator that they need an increase, but not always, because you have to remember that sometimes kids do things in fits and starts. You know, they'll concentrate on one thing that they're learning, and everything else kind of plateaus. So it's sometimes hard to tell whether it is a need for an increased dose or whether it's just because, you know, now he's working on speech, so his physical stuff has plateaued. But if you ever have a doubt, we can always check the levels.
Okay, but you think once every 3 months is plenty?
Usually at his age, yeah.
Okay. All right. Thank you.
No problem.
Okay, thanks, Ariel. I'm going to go ahead and mute you, and then we're going to move on to Shannon Williams. Shannon Williams has a question about lab work after a sleep study is completed. I'm going to go ahead and unmute her so that she can ask her question. Okay, Shannon, are you there? Oh, you know, it says she doesn't have a microphone. Okay, so I will read her question. It says, after the first lab work and sleep study is completed, how long do we usually have to wait to start growth hormone? Macy will be 1 on May 9th, and we have appointments May 4th, 5th, and 6th for a sleep study at the PWS clinic at Seattle Children's. So the question is, how long do we usually have to wait to start growth hormone after the first lab work and sleep study is completed?
It usually it can take up to a month, but usually about 2 weeks. If your endocrinologist is used to working with some of the programs like the Pfizer Bridge program, they can get you growth hormone usually within a couple of weeks. It just depends how comfortable your endocrinologist feels. Like, I know that there's nothing on that sleep study that's going to stop me from prescribing the growth hormone. There may be something that we have to do and treat at the same time as we start the growth hormone, like the mom whose kid who needed oxygen, but it wouldn't stop me from prescribing. It's just that we wait till we get the oxygen to start it. But many endocrinologists, especially if they're not familiar with Prader-Willi, will wait till they actually get the results of the sleep study, which at least takes 2 weeks, and then put in the prescription for the growth hormone if everything is fine, and that will take another 2 weeks to a month. So, so you probably want to talk to your endocrinologist about it and just say, you know, how long do you think this is going to take? You know, we'd really like to get her started ASAP because she's going to be 1, you know, and we want to get these benefits.
Okay. Let's go on to the next. Sorry. Okay, here's another one from Natalie. I'm going to go ahead and unmute her. It's about growth hormone and possibly delaying the phases. Natalie, okay, Natalie, are you there?
Hello again. Can you hear me?
Yes.
Okay, good. Yeah, I think I read or heard anecdotally that there was data that maybe supported the theory that the phases going on to the next phase, particularly the hyperphagia phase, could be delayed by early commencement of growth hormone. Have I dreamt that?
No, you haven't dreamt it. So the answer is that yes, it looks like with early growth hormone treatment, again, that's usually before a year, that the phases are pushed back just a smidgen. so that phase 3 usually in this group of kids doesn't start until around 8 or 9 versus the traditional what you read about, which is age 2 to 3. So to me, obviously it's better to have longer for us to find a treatment before they go into phase 3.
Okay. That's great. Thank you.
Mm-hmm.
And then, did you have another question, Natalie, about?
I had like 10. Sorry. So I think the other two that I asked, I'll do them quickly. First was, how do you arrive at the initial dose? And then second was, along the lines that Ariel asked, really, how long would you expect to wait to see a change? Gabriel's been on growth hormone about a month now. He's been ill for most of that time with a cold. And I think I saw him get a bit more spunky, I would say, and maybe want to roll a little bit more interested in things, and a little bit more active and wanting to move, but I wouldn't say it's been a phenomenal change yet.
Right.
Is that likely to be, he may need to go up a dose? He's only on 0.2. So those two are kind of linked, because I wondered how you arrive at the initial dose to begin with.
So the initial dose is based on his body surface area, which is like a very long equation that I can tell you if you really want to figure out what his body surface area is. But it's basically the starting dose is 1 milligram per meter squared, which is his body surface area, per day. So he's how old now?
He is just 9 months.
So his body surface area is probably at least 0.4, but maybe even 0.5. So he should really probably be on a higher dose, and that's probably why you've seen some improvement, but not sort of as much as you expect, although, he's been sick, so that could contribute as well. But I would say that he's been on it for a little bit. I would ask the endocrinologist to check levels and see if there's room to go up, because there probably is. The recommended starting dose for babies is 1 milligram per meter squared per day.
Okay. He said that he did two sort of calculations that sounded a bit like that, and both of them gave him, I think one was weight and one was surface area,
Right.
and both of them gave him 0.2 back in whenever we were talking about the doses. But we're getting this idea.
Young babies typically have a body surface area of around 0.2.
Yeah, so we were looking at that of at sort of 7 months in, but we're getting IGFs done and a repeat sleep study, which I'm dreading. So it's along the lines that I think he's snoring more, and that's what's worrying me. But it could be the cold as well. So we'll see. But I think he wanted to do the IGF and the sleep study together to give him an idea of what we were at. So I'll be in touch, no doubt.
Actually, it's a good idea. So yeah.
Okay. Thank you.
Thanks, Natalie. So the next question is from Amy. And she wants to know, when do you recommend to test after the initial startup of growth hormone? They just recently started. I'm going to go ahead and unmute her. Amy Montroy. Hi, Amy, are you there?
Hi, I'm here, but I don't know if I have a microphone that's working.
You're a little quiet.
We can hear you.
Oh, you can hear me. Okay. I didn't know if it was working or not properly, so. We have just started the growth hormone about 7 weeks ago, and we're just wondering when you recommend to do the first check for the blood, like the IG level.
So usually it depends on the child, but usually we do it around 2 to 3 months after starting the initial dose.
Okay. Okay, and how far after that, like, would you do, she's 2.5 years old, so after that, I guess it depends on the level, but is there a standard, like, our doctor had recommended every 4 months to check it?
Which is fine. At her age, because the growth velocity is slower after age 2, at her age, her dose is probably not going to change very much at all after this initial starting dose. So yeah, I think every 4 months at that age is totally fine.
Okay, because she's on 0.35 milligrams right now, but we don't know if that's the right dose yet because we haven't had it checked.
Right.
So.
Right. So I'd probably do it sooner than later. I'd give it 2 or 3 months and do it. But after you get on the right dose, which you'll know because the IGF-1 levels will be stable, then you don't need to do it as often at that age.
Okay, perfect. Thank you very much.
No
Nice
problem.
to talk to you.
You too.
All right, thanks, Amy. Next is Sandra from Australia. I'm going to unmute her. She has questions about what dosing you to start at. Let me see. Okay, well, she doesn't have a microphone. Okay, so her question, it says, in Australia, growth hormone is started at very low levels and slowly increased. To my understanding, growth hormone works best with a specific dose. The dose that is initially given in Australia is significantly lower than the recommended effective dose. Is it better to start low and go high, or does it really matter?
That's a hard question, and I honestly don't know the answer. We usually start at the recommended dose, which again is 1 milligram per meter squared per day, and then we adjust after that. Not everybody does it that way. I don't think there's any harm in doing it the way that they're doing it. It just takes longer to get to the best dose for the child. And so, but you can't really change clinical practice that easily, for endocrinologists, in other places. So, but what I do is I start at the recommended dose and then adjust from there.
Okay. She also had a question about, does growth hormone lower the child's immunity?
No, actually it usually strengthens the child's immunity. Not in everybody, but in a lot of people, they actually are healthier when they're on growth hormone. They don't get sick as often.
And she said, I think we start at 0.45 in Australia, which seems somewhat not too low.
No, it doesn't seem low at all, actually. Yeah.
All right. So we'll go on to the next one. The next one is Kelly Garner. She has a question about growth hormone and IQ. Let me see if she has a microphone. And Kelly, are you there?
I'm here. Can you hear me?
Yeah.
Hi, Kelly.
Yes. Hi, Dr. Miller. I love you.
How's my girl?
She's doing great. Yeah, we're excited to see you.
Can't wait.
Yeah. I was just wondering if you could help us all understand I've seen that there's correlations between starting early growth hormone and IQ improvements, but I haven't seen an explanation as to why this might be, and I was wondering if you had any kind of additional explanation for that, other than just the fact that the correlation exists.
Yeah, so I was talking to an investor for one of the drug companies the other day, and he asked me the same question, and I honestly don't know the answer. I suspect it's because there are IGF-1 receptors on the neurons, and the baby's brains start out normal, but we know when they're adults, if they never got growth hormone, they're not normal. So something clearly changes between being a baby and being an adult with Prader-Willi if you don't have growth hormone. So our hope is that by giving early growth hormone when the brains are still normal, we allow them to grow normally so that the IQ continues to progress pretty normally. But I don't know that that's the actual answer. We do know that many years ago they saw the same effect, that when they gave kids with Down syndrome growth hormone, their IQ got better. And so there's something to it. We just don't know why exactly that happens.
Okay, yeah, no, that's helpful. Thank you.
No problem. And just so you know, Sarah and Lillian will be here when you come, so you have to bring her over. You have to bring Elena over to play with her.
Oh, I would love that.
That's great. I'm so excited to come back. We miss it. That is, we miss it. Okay. All right, thanks.
That is a little crazy, I must say.
I know. Well, Lily even, she keeps asking when we're going to come back and see you. She's excited.
Aww.
But, all right, well, thanks, Kelly. I'm going to go ahead and mute you and go to the next question. The next question is from Cynthia Buenrostro. Sorry, I probably just butchered your last name, but Cynthia, I'm going to go ahead and unmute you. Her question is also about IGF numbers. Cynthia,
Can you hear me?
yeah.
Yes, can you hear me? Okay. I was just wondering, my daughter just started on growth hormones about a couple of weeks ago, and this is the first I heard that we needed to test her for IGH numbers, so I'm wanting to see to know that it's actually working or it's doing anything to her, what numbers should we be seeing?
So you want to see numbers that are in the upper 2/3 of the normal range. The normal range for little ones is huge. It's 25 to 280 something, and depending on the lab. And so what you really, for it to be most effective, you actually need to get those numbers up into the upper part of that normal range. So some endocrinologists will say, well, it's in the normal range, it's 45, that's normal. It is, but in Prader-Willi, a lot of times, and you'll see this as you go on, there are certain supplements that you have to dose a bit higher to get the most effectiveness, and it's the same with growth hormone. You have to dose it just a bit higher to get the best effectiveness for it. So, so you want those numbers in the upper 2/3 of the normal range.
Okay. Okay, sounds good. Thank you.
No problem.
All right, thank you. The next question is from, let's see, Andrea Piercy. She said, I don't need to unmute her. She just wanted to know, how often should you be checking levels in a 1-year-old?
In a 1-year-old, at least every 3 months is usually what we typically do.
Okay. The next question is from Devin. Is there a link between growth hormone and scoliosis? I'm going to see if I can unmute them. Are you there?
Yeah, we're here. Can you hear me?
Yes.
Yeah.
So, yeah, we just want to know if there's a link between that, because we were told by a pediatrician that, I think it was a pediatrician, that I guess is a spine going crooked because of the growth hormone. And also we had been told by, which was our pediatrician, that she can have one side of her body growing bigger than the other. So it should be crooked. And I don't know if it's the same thing or not.
So there's been multiple studies that have shown there's absolutely no relationship between being on growth hormone when you have Prader-Willi and having scoliosis. It doesn't worsen the scoliosis. It doesn't cause the scoliosis. So the answer is no to that. Now, the answer about the one side of the body, all kids with Prader-Willi, even in the mouse model of Prader-Willi, there's one side of the body that's stronger than the other. And it probably is true in other kids as well. It's just when you're lower tone, that stronger side tends to be a little bit more apparent. And that stronger side, those muscles, if she preferentially uses them, will kind of pull the spine to that direction. So what we encourage kids to work on when they're on growth hormone is that core muscle tone, to work both sides of the body equally and to not favor that side of the body that's stronger, because it's their natural inclination to do that. If that side of the body makes things easier because it's stronger, then you're going to turn that direction, you're going to use that hand, you're going to, you understand what I'm saying? So anyway, so we encourage them to use both sides of the body as equally as possible, and the PTs are really the best at doing that, making sure that they do that. That being said, some kids with Prader-Willi will still get scoliosis and it's a disease of the low tone, not the growth hormone. And so, sometimes we brace, sometimes we cast. I'm not an orthopedist, so I can't tell you how they decide which to do which, but it will get better over time, usually, with some sort of treatment.
So the better their muscle tone is, then the less likely they'll get this.
Correct.
Okay.
Correct. The lower the tone, the more likely they are to develop scoliosis.
Okay. Thank you.
Mm-hmm.
Thank you. Okay. We can move on to the next one. Let's see. Ariel had another question about the differences between starting growth hormone before the age of 1 and after the age of 1. Let me unmute her. Ariel, wait. No, it's not letting me. Okay, it's not going to let me unmute her. So her question is, what big differences have you noticed between the kids who started growth hormone before 1 year of age and the kids who started after 1 year of age?
There's several differences that we've noticed. The first is in metabolic rate. Those who start before 1 year of age, because growth hormone increases muscle mass, they tend to have a higher metabolism. So as they get older, they can eat a few more calories without gaining as much weight. They tend to have better body composition starting before 1 year, so better muscle mass and less fat mass. And we often even will see a little bit of an IQ difference, although that one's really hard to call because the IQ when the child is on growth hormone is more similar to that of the family than to anything. So it obviously varies from family to family, how the IQ ends up. But regardless, growth hormone improves your IQ no matter when you start it, which is nice. So those are the biggest differences are in metabolism and body composition. Aaron Carroll's group in Wisconsin showed years ago that starting growth hormone before 1 year of age improved acquisition of motor milestones, improved speech, and improved cognition. And we've seen the same, that the kids, just because they have more muscle mass, they tend to be a little bit more strong and do things a little bit earlier.
Okay, thanks.
Mm-hmm.
The next question is from Sasha Applebaum, and I'm not sure if I can unmute her. I'm going to try. Sasha, are you there? Hello?
Hello?
Hi.
Yeah. Hi. Can you hear me?
Yeah, you're a little quiet, but we can hear you.
Oh, good. Can you hear me okay?
Yes.
Yes.
Are you there?
Yes.
Okay. I don't hear her. I think she's coming in and out.
Oh, okay.
So, Sasha, I'm going to leave you unmuted.
Hello?
Yeah, there you are. Can you ask your question? Okay. So her questions were, let's see, let me find it. They kind of came in pieces. She's having some issues with growth. Let's see. We have had some issues with growth hormone with respiratory issues. So she's asking, she has a 9-month-old who still sleeps for a significant portion of the day. What kinds of supplements can I give to increase daytime wakefulness? She said,
Sasha, that's probably a question that would be better answered by us talking separately offline, just because since this is supposed to be specifically about growth hormone, but I'm more than happy to answer that question for you. But at 9 months, we often will use things like coenzyme Q10 or carnitine. And so if you want to email me, I can set up a time to talk to you and we can figure out what would be best for your child.
okay. I'm going to remute her since that didn't work out. Sorry, it's such a tiny little window that I'm reading these in. Okay, the next question is, sorry, there's so many and they're all kind of broken up. It's, okay. Sorry. Okay, Natalie has another question. I'm going to go ahead and unmute Natalie and let her ask her questions about growth hormone and Carnitor. Are you there, Natalie?
Hi, yes, sorry, I feel like I'm taking over, I didn't mean to. 2 questions. One, we started Gabriel on Carnitor at exactly the same time I started on growth hormone and then kicked myself afterwards because I realized I wouldn't really be able to, in my mind, tell which benefits were being caused by which. So my question is, are there very distinct benefits from Carnitor and growth hormone, or would it be sort of,
No, they're very similar. Both increase alertness, both increase tone and strength. So yeah, it's almost impossible to tell which is doing what.
Awesome.
But at this point, because he's still pretty young, and so at this point, I wouldn't even worry about it. I'd just keep both on, and then when he's around 3 or 4, we'll try taking off the Carnitor to see if he still needs it or not.
Okay, and then one quick question. Since starting, Gabriel had, at his ophthalmology appointment when he was 6 months old, they noticed his eyes wandered in. We agreed to just monitor it because it was very slight. I don't know if it's coincidental or not, and that's my question, but since starting growth hormone, I've seen that significantly worsen, and I wondered if it was something to do with muscle, anything to do with muscle improvement, growth hormone. Has there been any links between, worsening of eye issues with growth hormone because one muscle is strengthening? That was where I was thinking.
Yeah, no, that's an excellent thought, and I think there's not really anything written about eye issues worsening with growth hormone. And anecdotally, from the patients that I see, I would say to you that I feel like most of the time growth hormone actually improves the eye issues. But those kind of crossing in eyes are very, very common in kids with Prader-Willi, regardless of growth hormone or not. And it is a muscle tone issue. It's because, some of the muscles are a little bit weaker. And so often it will improve. Some of the kids have glasses that help it. Some of the kids actually do have to have surgery. But the answer is no, the growth hormone shouldn't have worsened it. It may just have worsened because that was what was going to happen anyway.
Okay, great. Well, it's good to know. Thank you.
No problem.
Okay. So there's another question by Ashley Gamble, and she said, "You don't have to unmute me, but how long are kids, how long are kids on growth hormone?"
Forever. Growth hormone is a lifetime medication. We find that the adults still get great benefit from being on growth hormone. And so my oldest patient on growth hormone is now 65. I just saw her on Monday. So we keep them on as long as we can. Sometimes the insurance companies do make us take them off when they're done growing and do a growth hormone stimulation test. But I know that the organization is working to try to get to the FDA to see if there's any way we can get growth hormone approved to be used in adults for the indication of Prader-Willi as well, because right now it's only indicated for children, but we know that the adults benefit in terms of quality of life, in terms of muscle mass, in terms of strength, and overall feeling of well-being.
Okay. Another question by Ariel was, can growth hormone counteract with other medications?
Oh, that's a good question. Unlikely. Kids, we have a lot of kids on growth hormone that are on, 50 million other different medications, and we've not really seen any side effects of growth hormone and other medications. If I think of something different, I'll email you, Ariel, but I honestly don't think that there is any drug interactions that I'm aware of.
Okay. Here, I'm going to go ahead and unmute her. I think she has more to say about that. Ariel, are you there?
Hello. Yeah, sorry. No, I just wanted to add to that. I had an exposure at work to somebody with pertussis, whooping cough, so they were concerned if I were to come down with it that AJ might as well, and it's very dangerous in children under 1, they said. Right. So we gave him erythromycin. An hour after we gave him the erythromycin, they had what he thought may have been a partial seizure, and I actually caught it on video. Yeah. I showed it to the pediatrician. He said it definitely looked like a partial seizure. He wasn't sure if that could counteract with the growth hormone. So then we gave him the second dose of erythromycin the next day, and an hour after giving it to him, he threw up quite a bit. Ooh. So I don't know maybe if he just had a bad reaction to the erythromycin or if it's somehow something with the growth hormone. I'm not sure.
My guess is it was probably the erythromycin, although erythromycin is a gastric motility agent. It moves things through the intestine a little bit faster and out of the stomach. And so we have a lot of babies that are on erythromycin and growth hormone because the erythromycin is used for their GI issues. So some kids do have sensitivity to antibiotics. It may have just been that he had a bad reaction to the erythromycin. But I don't know, quite honestly.
Okay, yeah, we're thinking that too, but I'd rather it just be a reaction from the erythromycin. Okay.
Yeah.
Okay.
All right, thank you.
Mm-hmm.
Okay. Since we have about 5 minutes left, I just wanted to ask you, and we've gotten through most of the questions, well, all of them that pertain to growth hormone. So I wanted to ask you, what is the biggest misconception of growth hormone?
I think the biggest misconception that's out there is the endocrinologists that tell parents that growth hormone causes death in children with Prader-Willi syndrome. That's the one thing I get asked a lot, and the answer is that as that data came out in 2003, but as it's been analyzed and looked at and whatever, it's been realized that there were other things that contributed to those deaths, not just growth hormone. And so I think that's the biggest thing that I would say to parents is that it is safe. We do, monitor the kids closely. And like I said, I still am cautious when they're sick. I take them off when they're having any issues. But really, it's a pretty safe and a very effective medication.
Okay. What are the biggest risks of growth hormone in our kids?
Oh, that's a good question. The biggest risk is probably the tonsil and adenoid growth. That happens, like I said, in a lot of kids, especially when you're first starting growth hormone, when you're going up on the dose of growth hormone, or when your kid is starting school and they're around other kids with illnesses that they haven't seen before. So their tonsils and adenoids get swollen from the illnesses plus the growth hormone. And so that's the biggest risk. If your child is obese, growth hormone can worsen the risk for diabetes because it does cause some insulin resistance. There are other risks if the growth hormone dose is too high, but in general, most people don't tend to treat with really high doses of growth hormone in Prader-Willi, so they're not significant risks. We've never seen any big problems with growth hormone.
Okay. And if you were talking to a new parent and they said to you, I really just want to see how my child does without it, what would your advice be to them?
I would say that's fine. I mean, it's obviously everyone's individual choice whether they want their child to be on the treatment or not. Knowing the benefits, I do think as the parent you have to weigh the benefits versus the risks in terms of waiting to see how they do. But everybody has their own individual thoughts about medications for their kid, and I can't override their thoughts by saying, oh, you should definitely do this. We have one kid in our clinic that's never been on growth hormone, and of course he had the appetite early and everything like that. But I mean, if you looked at the kid, you'd never know that he wasn't on growth hormone. He looks great, but then there are others, that end up very, very small compared to their family and very small for being an adult man or woman because they weren't ever treated with growth hormone. So it's very individual, and the decision is completely individual. And every parent has to make the decision based on their knowledge base for their particular child.
Okay. Well, thank you so much for answering all of our questions. I really appreciate that you were willing to take the time to do this. I know you're really busy.
Oh, no problem.
Especially with clinical trials going on and clinics and all kinds of stuff. It was amazing being there during the oxytocin trial and seeing people come in for the beloranib trial and the rhythm trial. And it's just, I don't think we really get a good view of what all you're doing in the background. But you've got a lot going on, and I just really appreciate you taking the time for all of us, and not just tonight, but I know that you are frequently answering questions for everybody.
No problem at all. And plus, it's fun, right? Isn't it fun doing these trials?
Of course, it is fun. I actually enjoyed it, and Lily did too. So we're happy we're going back. I have one more slide of pictures, and
oh, geez, more pictures.
There's some upcoming events and webinars I just wanted to let everyone on the call know about. This weekend is the Chicago Live Life Full Gala. There are still tickets, so if you feel like it, come on out to Chicago and go to fpwr.org to get the tickets. And if you go, come say hi to me. I will be there. And also, the new parent conference calls take place every 3 to 4 months. the next call. I'm still trying to decide which one, where we're going to go with that. So I will keep you all posted. But thank you. Thank you for everything. Thanks for coming on.
Picture.
Isn't it cute? So cute. Yeah. But anyway, thanks so much. And Dr. Miller, we will see you in a couple weeks.
All right. See you soon.
All right. Thanks.
All right.
Bye.
Bye.